So, hello everyone. Today we will discuss COBENFY. What is it? It is a dual muscarinic agonist. So, this is what novel about it. It has 0 D2 affinity. Unlike previous antipsychotics, in which main mechanism of action was through D2 antagonism. So if there is no D2 affinity, then how does it work? It basically do cholinergic regulation of dopamine. So let's understand it in more detail. So the active compound of COBENFY is xanomeline. Xenomeline. Xanomeline. And it is a dual M1 and M4 muscarinic acetylcholine receptor agonist. So it is a agonist of M1 M4 muscarinic acetylcholine receptor. So these postsynaptic M1 receptors resides in GABA interneurons. In VTA, ventral tegmental area. So in VTA, there is GABA interneuron, which has postsynaptic M1 receptors, and xanomeline is agonist. So agonism of these GABA interneuron, which will result in increased GABA activity to glutamatergic pyramidal neurons. And this increased GABA activity will inhibit these inhibition of glutamatergic pyramidal neurons. Since these glutamatergic pyramidal neuron used to activate dopaminergic neurons, in mesolimbic pathway, their inhibition will result in decreased dopamine activity in mesolimbic pathway. So this is the first action through post-synaptic M1 receptor. So what it does agonism of postsynaptic M1 receptor resulted in increased GABA, which resulted in inhibition of glutamatergic neuron, in VTA, resulting in dampening of dopaminergic neurons. Secondly, they also work on presynaptic M4 receptors of dopaminergic neurons. In mesolimbic pathway. So what happens when presynaptic M4 receptor in dopaminergic neurons in mesolimbic pathway are activated? Since they are G coupled and are inhibitory in nature, they will result in decreased activity of adenyl cyclase, further resulting in decreased CAMP, resulting in decreased calcium in the cell, and which result in decreased exocytosis, of dopamine. Resulting in dampening of phasic dopamine release. Although you must note that it does not affect the tonic release. Hence, there will be no motor side effect, no EPS. So now you understand. So let's understand with another picture. So here you can see xanomeline basically activates postsynaptic M1 receptor in GABAergic interneuron, which result in increased GABA, which result in inhibition of glutamatergic neuron. This inhibition of glutamatergic neuron, which will eventually dampen the mesolimbic dopamine neurons dopamine release. So it will basically dampen the activation of mesolimbic dopamine neuron, which will result in dampening of dopamine release in mesolimbic pathway. Xanomeline also activates presynaptic M4 receptor. So these presynaptic M4 receptors are GI coupled, which will result in decreased activity of adenyl cyclase, which will result in adenyl cyclase will activity will decrease, which will result in decreased CAMP, which will result in decreased dopamine release. And what kind of release this is? Phasic. Tonic release of dopamine will not be affected. Next, what does data says? We have the phase 3 data. Phase 3 data suggest that at 5 week, decrease in PAN-SS scores of COBENFY is more than 10 points higher than placebo. Also, secondly, at 52 weeks, there is 30% reduction from initial symptoms. So still we have only discussed the active compound, which was xanomeline. Now let's discuss the another compound, that is tropsium chloride. So what is tropsium chloride? Tropsium chloride is a pan-muscarinic. So what is tropsium chloride? Tropsium chloride is a quaternary compound. It is a quaternary amine which is pan-muscarinic antagonist, but it cannot cross blood-brain barrier. So it cannot cross blood-brain barrier due to its positive charge and high hydrophilic nature. So it is a quaternary amine which is pan-muscarinic antagonist, and due to its positive charge and high hydrophilic nature, it cannot cross blood-brain barrier. So still, what's its use? So historically, when xanomeline was given alone, There were intolerable side effect. Intolerable side effect due to its peripheral cholinergic toxicity. Cholinergic toxicity. Resulting in nausea, vomiting, sweating caused by panmuscarinic activation. So now when tropsium chloride was given, it does a work of peripheral shielding. So now tropsium chloride is basic, since it is a panmuscarinic antagonist, it will block all the M2 M3 receptor peripherally. So now since the peripheral M2 M3 receptors are already blocked by tropsium, xanomeline will not be able to occupy them. So it basically neutralizes the peripheral effect of xanomeline. And tropsium chloride cannot cross the blood-brain barrier, but xanomeline can. So now xanomeline, which can freely go through blood-brain barrier, will enter the CNS, and through its M1 and M4 agonism, it will result in the desired effects. Right? So that's how COBENFY solves this via high strategic pharmacokinetic pairing with tropsium chloride. Now, what are the clinical evidences? In phase 3 emergent 2 and emergent 3 trials, acute exacerbations of schizophrenia in adult patients randomized to COBENFY demonstrated a statistically significant and clinical meaningful reduction in PANSS, which we earlier discussed. At 5 weeks, there was greater than 10 points reduction difference in comparison to placebo. And at 52 weeks, 75% of patients reported more than 30% reduction in baseline symptoms. Now from how to prescribe it. We need to start COBENFY, that is xanomeline and tropsium, in 50 mg, 20 mg combination BD. We will start with xanomeline 50 mg and tropsium chloride 20 mg twice daily, and then gradually titrate it to 125 mg xanomeline, 30 mg tropsium twice daily. Another thing to note here, do not give it with food. It will alter its bioavailability. bioavailability decrease with food. So you need to take the dosing either 1 hour before food or 2 hours after the food. Notable side effects are, since tropsium is cleared by kidneys, it is not recommended to give in moderate to severe renal failure. Secondly, due to metabolic load of xanomeline, it is contraindicated in hepatic failure. Finally, watch for anticholinergic side effects driven by residual peripheral tropsium. Monitor for urinary retention. And avoid in untreated cases of angle closure glaucoma. So let's revise it. What are the contraindications? It is contraindicated in hepatic impairment, contraindicated in severe and moderate renal failure. It is to be avoided in untreated cases of glaucoma, and watch for urinary retention. Since the tropsium chloride may have residual anticholinergic effect, you need to watch for urinary retention. Dosing they need to be started with 50 mg of xanomeline and 20 mg of tropsium twice daily, and we can further titrate it to 125 mg of tropsium and 30 mg of 125 mg of xanomeline and 30 mg of tropsium twice daily. Avoid with food. So that's what you need to remember regarding COBENFY, as it is a potential question in your SS exam, or it may be asked in your MD exams. Thank you.